virtually all of these pharmacological treatments work by increasing All right, welcome back to our next lecture. This is our second to last lecture, believe it or not, and then you will be done with biopsych. So this is neuropsychiatric disease. This is a poster from Girl Interrupted, which is a really good movie that I liked from like forever ago. Okay, so I think that a good place to start here with neuropsychiatric disease is, what is a disease? And I think this is something that in our society we have a lot of trouble understanding because, or there's a lot of controversy surrounding it because a lot of people are affected with a variety of different disease states, right? So when people do have some kind of disease state, understandably, there is a lot of emotional feedback associated with that topic for those individuals because it affects their daily lives. It affects them every single day, and it's a big deal. So people will learn a lot about them, but this also means that it's talked a lot about in the general population, oftentimes in a context that's not super well educated about what it is that's being discussed. And so I don't mean that this about the people who are suffering from the disease state of interest, but I'm talking about people who maybe they talk to about it, and then those people have their own potentially uninformed or ill-informed opinions about these kinds of things. And I think that in general, a lot of people don't realize how our culture in the United States in particular, I don't know about other countries, obviously, but in the United States, we have a very individualistic society, and we also have a very evangelical kind of undertone to our belief systems and our belief structures. A lot of the United States, a lot of the citizens of the United States are Christian, and our country was founded in Christianity and in Christian values. And so that, I'm not critiquing that. I'm just simply saying that I think that contributes to a particular environment where we believe that we have a level of free will and a level of responsibility or a level of moral culpability that is potentially misplaced. And we see that with a lot of the diseases that we're going to be talking about in this lecture. So there are some diseases that people have no problem categorizing as a disease. Cancer, which, by the way, is not in of itself, that doesn't really mean anything. There are various forms of cancers. But if you just say I have cancer, you could have skin cancer or you could have a glioblastoma. And those are two very different clinical outcomes. You could have diabetes. And obviously we talked about diabetes mellitus and diabetes insipidus in our hunger and feeding lecture and our thirst lecture. You could have coronary artery disease. It's even got disease in the name, right? So that must mean that it is legitimately a disease. We have idiopathic hypertension. Hypertension is referring to high blood pressure, and idiopathic means that we don't know what is causing the high blood pressure. So you could have secondary hypertension as a result of, chronic obesity is the only thing that's coming to mind right now, but there's a lot of disorders that have secondary hypertension as one of the symptoms. But you could also just have idiopathic hypertension, which means that you have sky-high blood pressure and the doctors have no idea why. Your physician can't diagnose it, so you are diagnosed with idiopathic hypertension. There's also epidermolysis bullosa, which is a horrific condition. I think I just put that there because, honestly, I forgot that was in this lecture, but I think I put that there because of how absolutely undeniably horrific that disease is. So this is a disease where individuals literally don't produce a protein that's necessary to adhere, your skin cells to each other, roughly. So what happens is that their skin is extremely fragile and easy to basically take off of their body, but they have all of the same, their nociception is totally functional, so they can feel the pain that is associated with their skin tearing or being taken off their body very easily. And basically these kids just feel like they're being skinned alive a lot. They have horrific sores all over their body. They're oftentimes, depending on the severity, covered completely in bandages. If you Google this, I don't suggest that if you're sensitive to a lot of medical imagery that you should Google this, but if you do Google it, you will be horrified at the kind of lives that people live with. So I don't think that anybody would deny that these are real diseases, like real diseases, like whatever that means. But honestly, we don't even really know what a disease is in this context. Let's look at some other, the reason why I brought up the free will and the Christianity thing is because there are other diseases or disorders like drug addiction, obesity, generalized anxiety disorder, body dysmorphia, and anorexia. And these things are oftentimes seen as lesser disorders or disease states. Whether or not these are even classified as diseases kind of depends on the clinician that you're talking to. But the truth remains that whether or not there is some meaningful difference between a real disease that is biological or one that is, just somebody with weak willpower or the inability to control themselves, which is often said in conjunction with drug addiction and obesity, or if somebody just needs to grow up because they, are too afraid to go outside. These are the kind of things that people say about people that are suffering with these kind of psychological dysfunction. We also have body dysmorphia and anorexia. And by the way, anorexia has a horribly high mortality rate. So of all of the neuropsychiatric diseases, anorexia, if I'm remembering correctly, has the highest mortality rate of any of them. So anorexia is a very severe disorder. It's extremely challenging to treat. And it doesn't really help us by just saying that these people just need to, force themselves to eat, or that people that have generalized anxiety just need to grow up and, just go outside and just deal with it. You know what I mean? Like this kind of flagrant disregard for neuropsychiatric, psychological dysfunction, etc., is really not helpful if we want to have a functioning society when people are dealing with problems that we don't know how to treat or don't have a clear idea. So again, it's kind of hard to define what a disease even is. I mean, is it the opposite of health? I mean, then we have to figure out what health is. That's hard to define. Are you healthy if you can do 10 pull-ups? Are you healthy if you can't do a single pull-up but you can hang from the bar? Are you healthy if your blood pressure is below a certain point? Why does it even matter if your blood pressure is high? Classification of it as a disease changes over time. So osteoporosis, this is the weakening of your bones and the degradation of your bones over time. And this used to be just thought of as a normal part of aging. It's just like, yeah, dude, your shoulder hurts and your bones hurt because you're getting old. That's what happens when you age. But in fact, we now have a lot of treatments that are associated with osteoporosis. And so now that we understand what causes it, and now that we have a treatment methodology that can prevent this kind of that can prevent osteoporosis, we now classify this as a disease, and we help the populations who it affects. And conversely, we have diseases that are no longer thought of as diseases over time, like homosexuality. Obviously, people are probably going to be familiar with this from other psych classes, but being gay used to be in the DSM as a psychological disease. So sometimes the classification as diseases will fluctuate, where things become classified as diseases later on, and other things are declassified as disease states. And then what about human behavior that is typical but disturbing? I mean, there's a lot of sociopaths that are walking around. There are people that are in our society that do not care about how their behavior affects other people. And honestly, this is kind of normal for human beings. There's a huge percentage of people that are sociopathic in some way. And what about sadistic individuals, people who enjoy or have, and this isn't about like kink shaming or something like that. Like there's obviously spectrums to all of these things, but there are people who are sadists outside of S&M kind of context that are not doing things consensually, who legitimately just enjoy, like sadism is finding pleasure out of hurting other people, and this is not necessarily. I mean, what do you say about that? I mean, how do you define sadism as a disease because it deviates from normality? I mean, I'm just trying to point out the whole point of this. What is he talking about for the last 10 minutes? The reason why I'm giving such a PSA on this is just to point out that when the general population has a view about certain concepts like disease or science, and they think that it's so clear cut that a disease is cancer, alcoholism is not a disease, right? Those are the two categories that we're talking about. But when you actually start to look at what different various cancers are, or how we even define disease, you will find out very rapidly that there is not that much of a difference between the two. So if you're saying, well, a disease is something that we understand the cause of. We don't understand the cause of a variety of diseases. If you say, well, a disease is something that's biological in nature, it's like, okay, well, I mean, obviously from this entire class, the point is that your psychological outputs are biological in nature, right? So unless somebody can prove a soul's existence, it seems very likely that your behavioral output is directly related to your biological predispositions. Anyway, okay, so let's move on. So a disease is any harmful deviation from the normal structure or functional state of an organism. That's how we define disease. But these are just words, and definitions are really only here to serve us. You know what I mean? So at the end of the day, cancer in of itself doesn't exist. Like, cancer is a description. If you're saying a glioblastoma, that is a description of something that's happening in a glial cell with the inability of cells to go through a proper cell cycle, for instance. So the whole point of using a word like disease is not to put diseases or disorders into a hierarchical structure and say, well, I'm allowed to feel bad for you if you have stomach cancer. But if you're an alcoholic, or if you struggle with obesity, or if you have anxiety disorder, then I don't really feel bad for you because realistically you have control over those things. I think that that's kind of the point of this. I'm trying to dissuade you from the former opinion that is quite prevalent. So what about a society where everyone had auditory hallucinations? Would that be a disease, right? So again, diseases and the classifications of diseases are about deviations from normality, and whether or not those deviations from normality have pathological outcomes and consequences. What does it matter if you have a deviation from normality that has no consequences? People like to collect video games. I've been collecting PlayStation 1 games. I don't know why. I collect VHS tapes and cassette tapes, and it's like, is it hoarding? It's like, well, no. I mean, like, I can still move through my house, but people come over, they see my collection of VHS tapes, and they're like, dude, what is wrong with you? Like, you're trying to recreate Blockbuster from 1999. Anyway, let's go ahead and look at the difference between neurological diseases and psychiatric diseases. So this first point here, hopefully not wasting, and if it is a waste, then you can put me on 2x speed. But the whole last 10 minutes is just to try to get through to us that the definition of disease, what a disease is not as clear cut as you may think if you just kind of flippantly use the word, okay? And as many things in this class, or as I've hopefully have kind of pointed out, is that definitions are extremely important when we are trying to have nuanced discussions about complicated topics. So let's go ahead, and the title of the lecture is neuropsychiatric disease, right? But this is really a compound of two separate classifications of diseases. We have neurological diseases, which are pathological outcomes that are a result of damage or malfunctioning nerves or nuclei. Okay, so this is something where we can kind of point to a part of the nervous system and say, that thing right there, that neuron is messed up, that area of the brain is messed up, that area of the spinal cord is messed up, and that's why we're getting this pathological outcome. Or it is something similar to the effect of, like, although we may not know the originating cause, we have a pretty good idea that it's associated with disruption of dopamine or norepinephrine or something like this. Psychiatric diseases, on the other hand, are disorders that affect psychological and or behavioral states. And so this will become hopefully pretty clear as we're going over some examples of different neurological diseases and psychiatric diseases. Also, I do want to point out that whether or not the word disease is used or disorder is used can depend on the clinician. And realistically, I think that this is a topic that is not so clear-cut in medicine. So I know some psychiatrists who would not define psychological diseases as diseases. They would say that they're psychological disorders or psychological dysfunctions. I know other psychiatrists who would define psychiatric illness as a disease. So it kind of just depends on the person's training and background, but ultimately at the end of the day, the point remains that whether we call something a disease or a disorder, all that we really should care about is whether or not we have an understanding of the pathological thing that we're talking about, and if we can treat that pathology. So let's go ahead and go over some examples of neurological diseases. This is myasthenia gravis. This is a pretty common neurological disease to talk about because it has to deal with the communication of motor neurons with actual muscle fibers, okay? So the way that your muscles contract after your nervous system is sending a signal to contract is through these motor neurons that are directly communicating with the myocytes. So you have muscle. The muscle is composed of cells. Those cells are called myocytes. Your myocytes have receptors on them for acetylcholine, which you may remember from some of our earlier lectures is an excitatory neurotransmitter. And myasthenia gravis is a degradation of the neuromuscular junction, which results in severe muscle weakness. So the neuromuscular junction is that connection between the myocyte, which is the muscle fiber or the muscle cell, and the motor neuron that's synapsing onto it. So it almost always affects cranial muscles, eyelids, eye muscles, oropharyngeal muscles, and limb muscles. So basically the ability just to move around is extremely difficult. It feels like you have a weighted vest on you. The severity of symptoms varies in the course of a single day and from day to day over long periods of time. And this is a unique characteristic of myasthenia gravis compared to other diseases of muscles or nerves, like we'll talk about with Parkinson's or Huntington's disease. So sometimes people with MG will have good days and sometimes they'll have bad days. And as far as I understand, this weakness, it kind of feels like if you're, trying to like punch somebody in a dream and it feels like you're kind of punching through a bunch of water or you're trying to run away. This severe muscle weakness is what this is basically characterized by. So there's no conventional clinical or electromyographic signs of denervation, which is kind of going back to my point, which is like this is no doubt a neurological disease, but it's, again, not something that people tend to associate with diseases where it's like people seem to think that we have, a disease is something that we can point to the biology and diagnose. But this is a disease that is diagnosed by the behavioral outcome and the subjective effects of muscle weakness, right? So you can't necessarily just go over and diagnose these people with a blood test. This weakness is reversed, though, by drugs that inhibit acetylcholinesterase. And so acetylcholinesterase is the enzyme that degrades acetylcholine. So if you remember from our synapse lectures, we talked about how one of the ways to stop a neurotransmitter from having actions is from enzymatic degradation. So acetylcholinesterase is the enzyme that degrades acetylcholine, and one way that you can treat MG is by giving an acetylcholinesterase inhibitor, and that's because the thought or the hypothesized mechanism of MG is that there are essentially it's an autoimmune disorder where we have these antibodies that are connecting with these nicotinic acetylcholine receptors. Nicotinic acetylcholine receptors are just a type of ionotropic acetylcholine receptors. So you won't need to know that level of detail on the quiz or the exam. You'll need to know that the treatment for myasthenia gravis is acetylcholinesterase inhibitors. You'll need to know that myasthenia gravis is a degradation of the connection between motor neurons and the actual musculature itself, and is characterized by muscle weakness. And that it's thought to be an autoimmune disorder, which is happening when these antibodies are attacking these acetylcholine receptors. So the part that you don't really need to know is that it's nicotinic acetylcholine receptors, and that nicotinic acetylcholine receptors are ionotropic in nature. This is just, in case you happen to care. So anyway, the acetylcholine can't actually properly connect with its receptor because of these antibodies that are essentially working as antagonists, more or less. And this is thought to cause the muscle weakness because there's not enough acetylcholine hitting the receptor site. So that's why an acetylcholinesterase inhibitor is thought to provide some relief from this disease, is because if you have more acetylcholine that's in the synaptic cleft, then you're going to have more opportunities for it to bind with the receptor and relieve some of that muscle weakness. So Parkinson's disease, this is what Muhammad Ali had. This is something that it seems like a lot of fighters develop over time. It's a common neurodegenerative disease or disorder, and it affects 1% to 2% of the population older than 65. And the symptoms are resting tremor, bradykinesia. So bradykinesia is just like a reduction in normal movement ability and speed. Oftentimes in physiology or in clinical settings, when you hear Brady, that normally means like below average. So if you have bradycardia, that means that you have like a low heartbeat. I think that's technically, if you have a heartbeat of 60 or below, you have bradycardia, which can be pathological or just because you are in really good shape. Muscle rigidity, which is, meaning it's hard to move, impairment in their ability to initiate and sustain movement. These people develop a shuffling gait, which is referring to the way that they walk. It kind of has a shuffle to it. They have difficulty balancing, and there are spontaneous facial movements are diminished, and so they have like what's called like a mask-like face. So more or less, Parkinson's disease is essentially a movement disorder where people, it's a neurodegenerative disorder, but it's manifest in the inability of people to move around properly. And this is due to a death of dopaminergic cell bodies in the substantia nigra, and there's no known cause. So again, I just want to point out that although we do have a biological mechanism for what Parkinson's disease is, which is death of dopamine cell bodies, and when you have a death of these dopaminergic cell bodies, you have all of these symptoms. There's no known cause for why the dopamine cells are dying. So here is a cross-section of a brain that has Parkinson's disease, and the substantia nigra is this part of the brain tissue right here that I'm highlighting. And you can see the reason why it's named substantia nigra is because of this characteristic black grouping of dopaminergic cell bodies. And you can see that in the Parkinson's disease brain, you can see a huge reduction in this darkened area, indicating a death of these dopaminergic cell bodies compared to the normal or the non-Parkinson's disease brain. So again, we've gone over this pathway maybe very briefly in other lectures, but this is a common movement pathway that originates in the substantia nigra, which is this dopaminergic nucleus, which then projects to the striatum. And this is the nigrostriatal pathway. The nigral-striatal pathway is typically associated with a variety of movement and control of movement. So as you'll see in the next disease, having not enough dopamine causes Parkinsonian disease-like symptoms, and having too much dopamine can also cause movement disorders. So realistically, in order for you to move around properly, you really need a specific tone or dopaminergic signaling. And if you have too much or too little, then you get pathological outcomes on either end of that equation. So the treatment for Parkinson's disease is L-DOPA, and L-DOPA is a precursor for dopamine, and that's because they don't just give dopamine, because dopamine itself doesn't just pass the blood-brain barrier. You'd have to give a shot that bypasses the blood-brain barrier, which is not really feasible. So you can give L-DOPA in a pill, and that will eventually get to the brain and become dopamine. I basically said all this already. It eventually loses efficacy, though, because neurons become sensitized to its effects, resulting in severe dyskinesia. So the dyskinesia is essentially like abnormal movement patterns. So you'll see sometimes people with Parkinsonian symptoms or Parkinson's disease, and we think about them having tremors and moving around in odd ways, and that's not actually from Parkinson's, it's from the treatment for Parkinson's. So once this death of this dopaminergic cell bodies starts happening, there's no way to stop it. Like, we don't know what's causing it. All we know is that once it happens, people have severe motor deficits, and the only way that we can combat it is by giving dopamine, or L-DOPA, the precursor. But you kind of lose either way, because eventually you're going to develop reactions to these dopamine through this dopamine activity, which is pretty common with dopamine. Too much dopamine is also not good. So, and that brings us to Huntington's disease, which is an inherited disorder caused by a genetic deficit on chromosome 4. So here's a disease where we actually have incredible resolution in our identification of the cause of the disease. However, we don't have any way to really fix it. The disorder causes progressive degeneration of nerve cells in the brain, resulting in movement, cognitive, and psychiatric symptoms. Huntington's disease is a really horrific disorder. It's grouped within motor diseases due to the characteristic shaking and jerking movement. So this is what I was talking about with the sensitization to L-DOPA. Sometimes people with Parkinson's can resemble people with Huntington's disease, but it's totally different. Huntington's disease actually is characterized by this shaking and jerking movement that is actually thought to arise from too much dopaminergic activity. Fine movement is impaired. There is rigidity, dystonia, problems with speech and swallowing. And this is why, Huntington's disease is so sad, because the cause of death is typically due to an inability to swallow, falls, and pneumonia. So people literally eventually lose the ability to, just swallow and have normal function. There's also significant cognitive decline associated with Huntington's disease. So Huntington's disease is a horrific situation to find yourself in. There are some biological markers outside of the genetic predisposition on chromosome 4, which is which are large ventricles. So these are the lateral ventricles, where, if you remember from neuroanatomy, are these basically these cavities in the brain that is filled with cerebrospinal fluid. And people with Huntington's disease actually have enlarged ventricles pushing up against the caudate nucleus and the putamen, which are nuclei that are associated with movement. And this severe degradation of the dorsal striatum results in the movement pathology. So the caudate nucleus and the putamen is referring to various aspects of the striatum, which we showed here as part of that nigrostriatal pathway, which is the substantia nigra to the striatum, causing these motor deficits. So unfortunately, there's no treatment for Huntington's disease to delay or really reverse the outcome. And as you can see here, the difference between a healthy brain and this brain of this person who had Huntington's disease, there's just severe atrophy happening all throughout the brain. I mean, this is absolutely horrific to see. There are some symptomatic relief that can be found with drugs that decrease monoaminergic packaging, so neurotransmitters like dopamine, serotonin, norepinephrine. But reducing dopamine ultimately results in some pretty severe side effects, including Parkinsonian symptoms and depression. So, this is the kind of the problem with, not a problem, but just like the limitations of Western medicine is that we just have this idea that like all these diseases can be treated and just go to your doctor and they'll fix you up. But realistically, there are many disease states that we just don't have good treatments for, and the treatments that we do have for them have severe side effects. So it's a really terrible thing to have. So moving on, we have amyotrophic lateral sclerosis, or ALS. It's also called Lou Gehrig's disease, and this is what Stephen Hawking had. Also Lou Gehrig, who was a baseball player who the disease is named after. It's a neurodegenerative disease with primarily motor symptoms. And there's a degeneration of upper and lower motor neurons, which results in loss of fine and then gross motor function. This typically leads to death from respiratory failure within 5 years, but Stephen Hawking actually lived for 55 years with this condition. So obviously there is quite a range to the prognosis of people with ALS. And again, a really kind of horrific situation here where respiratory failure is typically how people die, and that makes sense because the motor neurons are degenerating over time, which means that eventually the motor neurons that are allowing your diaphragm to open your lungs up are going to fail, which means that you won't be able to breathe without assistance. Death of motor neurons leads to disruption of the cytoskeleton and aggregation of neurofilaments with other proteins to form these little things that are called spheroids. And this leads to proliferation of astrocytes and microglia producing neuroinflammation. So again, the reason why there's no, that there aren't treatments, or that treatments with little side effects are so rare, is because in biology there's really no free lunch. Your body is trying to fight the death of these motor neurons and the aggregation of these neurofilaments by producing microglia and by sending astrocytes to try to help these immune cells and these support glia to try to help the situation, but that ultimately will cause neuroinflammation, and the inflammation will cause further damage. You know what I mean? So biology is not perfect. It's a flawed system. There's characteristic scarring in the spinal cord caused by a loss of lateral corticospinal tract neurons, and the cause of the motor neuron death is ultimately unknown. There's a hypothesis that excitotoxicity from excessive glutamate, the aggregation of proteins and breakdown of axonal transport, reduction of production of ATP, neuroinflammation triggering of cell death. So there's a lot of these things down here that people are hypothesizing might cause ALS, but realistically we just don't know why ALS is happening. So that's a lot of dense information down here. What you'll need to know for the exam is that it is a neurodegenerative disease with motor symptoms that ultimately make it so your motor neurons are dying, and there's not a whole lot that you can kind of do about that. So it's the death of motor neurons. I think that's probably what I'm going to be asking on the exam. There's no cure. There are drugs like Riluzole that can increased survival by a couple of months, and it inhibits glutamate release, which is why there is some hypotheses that this might be due to excitotoxicity from excessive glutamate release, but ultimately we don't know. And then also there was a treatment that was produced from the Ice Bucket Challenge, edaravone, which gets rid of the free radicals that are associated with ALS, and thought to be neuroprotective by reducing oxidative stress to neurons. But honestly, I didn't find a whole lot of information on the efficacy of this. So the textbook says that it slows physical decline, but honestly, when I was looking into it, I was having trouble finding the actual clinical benefits of this. So I think, unfortunately, like the other diseases that we've been talking about, ALS just doesn't really have a good treatment option. Okay, so now we're moving, we're still in psychiatric disease, but we're moving towards kind of the realm of psychiatric, or I'm sorry, we're still in the neurological diseases, but we're moving towards the realm of psychiatric diseases. So that's why I kind of structured it in this way, moving from motor diseases to something that we normally think of as affecting memory. But we have Alzheimer's disease, which is a chronic progressive dementia disorder. So dementia is an umbrella disease state. So dementia itself is referring to many different disorders and diseases, and Alzheimer's disease is one of those dementia disorders. 50 to 70% of individuals with dementia have Alzheimer's disease, and the risk increases as you age, but there is also an early onset variant of Alzheimer's disease. And this is defined by Alzheimer's disease before the age of 60. It progresses rapidly and has a genetic basis, and Alzheimer's disease is diagnosed as mild or major neurocognitive disorder. It's characterized by memory loss, the inability to communicate, loss of physical abilities, and people can become unresponsive or nonverbal. On a biological level, it is thought that it is due to a buildup of amyloid plaque in neurofibrillary tangles. So we have the production of these alpha-beta proteins that accumulate, that ultimately cause inflammation and produce these things that are called amyloid plaques, as well as these neurofibrillary tangles, which is thought to result in a decrease in neurotransmitter activity, ultimately producing cognitive and the behavioral abnormalities that are characteristic of Alzheimer's disease. Although there has been some controversy within the last 5 years about the actual nature of Alzheimer's disease, and if it is indeed the fact that these amyloid plaques are actually causal or just a response to the disorder itself. Okay, and I have these two sections here on amyloid plaques and neurofibrillary tangles, but I'm honestly likely not going to go into it. I don't think that you need to know much more than just the fact that these amyloid plaques and neurofibrillary tangles are characteristic in individuals that have Alzheimer's disease. The risk factors are advanced age, family history, a history of head trauma, hypoxic brain injury, which means having lower oxygen for some period of time. So if you are unable to breathe and your brain is deprived of oxygen. Depression is a risk factor, bipolar disorder, PTSD, and there are certain genetic markers for this, but ultimately you can't fully diagnose Alzheimer's disease unless you do a post-mortem analysis. Alzheimer's disease is defined by changes that happen in the brain during the degenerative process, which is that plaque and tangle accrual. There's no definitive test to say for sure that it's Alzheimer's disease until these are observed in the brain, and therefore diagnosis relies on ruling out other forms of dementia. So it's a disease of exclusion, meaning that once you've excluded enough other dementia disorders, then you will land on Alzheimer's disease until the individual passes away and you can do an autopsy and look at the brain. Okay, so we're going to move on now to psychiatric diseases. And these are disorders that affect psychological and or behavioral states. So in psychology, they use a biopsychosocial model to explain a variety of disease states. Obviously, the age, gender, and genetic predisposition is extremely important. Physiological reactions. Some people have more severe physiological outcomes to certain stimuli than others. Tissue health, etc. Mental health, emotional health, beliefs and expectations. But yeah, believe it or not, no pun intended, beliefs and expectations have a huge outcome on people's resilience towards a variety of disease states. So ultimately, there always will be a limit. I mean, if you have lung cancer, like, you can't just will your way out of that. You can't stop yourself from dying when you have a certain disease state. I mean, people with alcoholism can't just, will themselves into being able to have alcohol socially. But if you have a strong internal locus of control and you accept your situation, you say, okay, look, yes, I may be a drug addict, or I may have, alcoholism, so I can't control how much I consume, but I can, decide that I'm going to not drink. You know what I mean? Like maybe I don't have control over myself once I start drinking, but maybe you have control over yourself before you start drinking. And so then you decide to, not, to eating alcohol or drugs, whatever your triggers are. So beliefs and expectations play a huge role. Having an internal locus of control and believing that you have the capacity for change is a huge boon and benefit to outcome. Now, how do you convince somebody that has a weak internal locus of control, or kind of just feels like a leaf in the wind, that they can have some control over their lives, even though so much of their lives are not up to them, like their genetic background and their environmental setting and stuff like that? It's not easy. It's an unknown factor. And then obviously sociological pressures are going to have a huge effect on disorders. So people's interpersonal relationships, whether or not they have support, whether or not they come from a low socioeconomic background or have a lot of wealth available to them, these things are all going to play a very large role in whether or not somebody has a good or a bad psychological outcome. So psychiatric diseases are disorders that affect psychology and or behavioral states, as we've already said. And there's not a single objective biological measurement to diagnose mental health disorders. So that's a pretty important situation to talk about. So whether or not it's ADHD or bipolar disease or schizophrenia or any of the psychiatric diseases that we're going to talk about, there is not a single objective biological measurement to diagnose these disorders, okay? So if you have somebody on TikTok that's saying you just need to go get an fMRI to diagnose your ADHD, that is absolute BS, okay? I'm telling you, it is not true. You cannot just go get an fMRI. You cannot just go get a blood test to diagnose these things. There's a huge movement talking about, specifically on TikTok, talking about the misdiagnosis of this or that, and if only you were diagnosed properly, then you would get the correct treatment. It's BS. There's no biological measurement to diagnose these. They are correlations between certain markers and brain states, but you can only be diagnosed based on your behavior and your self-report. So definitionally, psychological and psychiatric diseases are defined and diagnosed based on behavior, which means that there is going to be a variety of psychiatric and psychological diseases that are difficult to define or properly diagnose. So starting off with probably the one that most people are going to be familiar with, MDD, or major depressive disorder. Major depressive disorder is defined by feelings of sadness, helplessness, most of the day, every day, for weeks at a time. This is really hard for people that do not have depression to empathize with, because it's almost like when you see somebody getting a tattoo and you're watching them get tattooed, and I don't know about you guys, but for me, it's almost like, I'm covered in tattoos. It's like I know what it feels like, but it's almost like I forget how much it can hurt depending on where you're getting tattooed. So like your ribs or your chest or your back or your foot is absolutely horrific. Your armpit's really bad. It's almost like when you're watching these people getting tattooed, it's almost like, what's the big deal? Like just chill, breathe, you'll be fine. But when you're actually experiencing it, it's a whole different animal. And individuals with depressive disorder who will have low motivation or attention problems, it almost feels like to their family members, like, just snap out of it. Like, why can't you just be normal, just go throughout the day and just get done what you need to get done. And the reality is that when you have this internal monologue, or this, it's honestly, from what I understand, it's much more than just an internal monologue. I mean, a negative internal monologue is part of it, but there's a hole in individuals that have this disorder, a ball in your throat and a hollowness in your soul that really eats at you. And some individuals are able to turn that into incredibly productive outcomes by becoming addicted to exercise or work, etc. And other individuals react to it with, not showering for weeks at a time, for not brushing their teeth, by, not being able to get out of bed, not being able to go to work. I mean, the reaction to this internal state of suffering has a wide variety in between individuals, which makes it extremely hard to accurately diagnose. But the point is that these individuals do not have control over this internal state. This is something that, it doesn't matter what your locus of control is or your belief system. When people have this, this overwhelming helplessness that surrounds their internal being, there's only so much they can do. I'm not saying that it's helpless or hopeless and that you shouldn't try every day to treat the disorder. That's not what I'm saying. I'm not saying give up, but I'm just trying to advocate for empathy for individuals who you may find frustrating because you just don't understand why they can't just get out of bed. Low motivation, impaired memory, absence of happiness. That's another thing that I think is really hard to empathize with. It's like people might say, just get a hobby, just get a girlfriend, just get a boyfriend. Like, what's the problem? And, what if, I think that a lot of people have the experience of, getting somebody's number, calling them up, or like getting that snap from somebody and just being like, you get the butterflies, or maybe you accidentally touch their hand while you're walking together and you get the spark of electricity or whatever. Some individuals that are suffering with this, they don't feel any of that. Maybe somebody asked them out and it's okay, fine, whatever. You know what I mean? It doesn't even matter. Maybe they have some feeling towards somebody, but they don't feel that electricity. They don't feel that the excitement when they get the new Pokemon card that they've been looking for. Maybe you're into cars and that's your hobby, and they just don't care about the cars anymore. You know what I mean? Like, so this absence of happiness is called, or this loss of interest in normally enjoyable activities, called anhedonia, and it can be extremely devastating because individuals may go through their whole life feeling normal until they have a bout of major depressive disorder. And maybe they used to really enjoy going out on dates. Maybe they used to really enjoy working on their car or, hunting for that Pokemon card or whatever. And now they get a first edition, Shadowless Charizard and they just don't care. They get asked out by somebody had gym crush on, and they just don't care anymore. This is a very common symptom, and it's very discouraging. They tend to report to have average number of unpleasant experiences, but far lower pleasant ones compared to individuals without MDD. So, that's another really important characteristic of the disease, which is that while it's not necessarily that they're having a greater number of bad days, but they just don't have any good ones. It's very unfortunate. Also, sleep problems is a big association, whether it's insomnia or oversleeping. Both of those can be associated with MDD. And then this is just showing again that with many of these disorders, there tends to be biological markers or biological trends or correlations that are associated with them. And here you can see people that have depression or people without depression have variations in things like their body temperature and their sleep cycles. Okay, so treatments for MDD are tricyclics, SSRIs, SNRIs, MAOIs, and atypical antidepressants. So tricyclic antidepressants are named because of their chemical structure. And they bind to transporter proteins and inhibit the reuptake of serotonin and norepinephrine. So that's why it's actually the reason why it's called a tricyclic is because of the actual chemical structure and this 3-ring structure that they have. But they enhance monoamine activity like serotonin, dopamine, and norepinephrine, and this enhances mood. However, there are side effects. They block histamine receptors, which can result in fatigue. It blocks acetylcholine receptors, which blocks acetylcholine activity, which can result in dry mouth and difficulty urinating. And it can block sodium channels, which can ultimately lead to heart irregularities. So tricyclic antidepressants are kind of old school. They can be used at times, but they're not as prescribed as SSRIs, which are selective serotonin reuptake inhibitors. I believe we already kind of went over this in our psychopharmacology lecture, but they have a similar mechanism to the previous drugs, except for they only bind to serotonin transporters. They have similar levels of therapeutic value, but less side effects, which is often the goal rather of pharmaceutical companies and pharmaceutical treatments, is to not necessarily get a more effective treatment, but to get one that's more specific, so you have less of those side effects. There's also serotonin and norepinephrine reuptake inhibitors. So there's selective serotonin reuptake inhibitors, and then there's an SNRI, which is a serotonin and a norepinephrine reuptake inhibitor. And this blocks the reuptake, as you might guess, of both serotonin and norepinephrine. They're about as equally as effective as SSRIs. And then there's monoamine oxidase inhibitors. So the way that these reuptake inhibitors work is by blocking the proteins that vacuum up all of the excess neurotransmitter, which results in more neurotransmitter in the cleft, if you remember from our synapse lecture. Monoamine oxidase inhibitors, as I've kind of already alluded to with the acetylcholinesterase inhibitor, is another enzymatic inhibitor. Okay, so monoamine oxidase is the enzyme that actually is going to break down monoamines like dopamine, norepinephrine, and serotonin. But if you block the monoamine oxidase with an inhibitor, then you have more of these neurotransmitters that can hang around in the synaptic cleft. It increases time that monoamines are left in the cleft before being removed. The earliest antidepressants used, meaning that these are the oldest ones, only used today for patients who do not respond to other antidepressants. It creates certain diet restrictions like cheese and raisins, and avoiding foods that contain, this should say tryptamine, and can cause blood pressure issues. So basically for these treatments, what you'll need to know is just that monoamine oxidase inhibitors are the oldest, and then that SNRIs, SSRIs are reuptake inhibitors and which one they are inhibiting. And then they have atypical antidepressants like bupropion, which inhibits the reuptake of dopamine, or any other depression treatment that doesn't fall under the previous categories are basically just put into this atypical antidepressant category. So basically, all of these treatments increase monoamine activity at the synapse. Okay, because of this, the held view is that MDD is a disorder of dysregulated serotonin. But there has been some evidence recently, within the last 5-10 years, that has really put some doubt into that hypothesis, primarily that people with MDD or diagnosed with MDD don't actually tend to show less dopamine. Less serotonin. So nonetheless, sometimes treatments are still prescribed even if the mechanism is unknown, because the clinical outcomes are sufficient or better than placebo. And antidepressants depending on the particular dysfunction and depending on the particular medication, tend to work better as treatment methodologies, especially when they're combined with cognitive behavioral therapy and other talk therapies. So, bipolar disorder is defined by a fluctuation between depressive-like symptoms, like we just kind of went over in MDD, like anhedonia, lack of interest, lack of motivation, etc., and mania. And mania is actually a very scary symptom, because a lot of wild situations happen when people are in manic states. Gambling can happen, suicide can happen. People will just get up and leave get on an airplane sometimes. I mean, like, true manic episodes are very similar to when people are on a very high dose of psychostimulants. So mania is very tricky because sometimes people really get addicted to their manic episodes and they don't want to take the treatment that is associated, that would be a stabilizer for them. So this can be a really tricky disorder to treat because sometimes, like I said, people enjoy the mania. But those manic episodes can lead to really scary, horrific outcomes. So mania is, I kind of already described it a bit, but it's characterized by restless activity, excitement, excessive self-confidence, rambling speech, and a loss of inhibitions. There's two types of bipolar. Bipolar 1 is people with full-fledged manic episodes. And bipolar 2 are people who have hypomanic episodes. So again, this is just the difference between somebody who's having a full-fledged manic episode, which might result in them, killing themselves or, selling their house on a whim, or that's a kind of a slow process. So maybe that's not the best example, but maybe they go and sell all of their jewelry, their wedding ring, or, whatever, to a pawn shop because they're going to go invest in drop shipping and, they needed that money. So full-fledged mania can have horrific outcomes. Hypomanic episodes can also have horrific outcomes, but it's not generally as severe as a bipolar 1 manic episode. The onset is normally during teenage years, and this is again just showing the kind of brain activity that is associated in people that are having manic episodes here. So again, you can't put someone in an fMRI and just say that based on this, I can tell that they have bipolar disorder, but these kind of biological correlations can be made. So the treatment for mania is lithium salts, which is a mood stabilizer. It reduces hyperactivity. It's ineffective at lower doses and can be toxic at high doses. So it's always kind of a balancing act between having enough to treat the mood disorder, but not too much to have toxic side effects. So you'll need to know basically that there's bipolar 1, which is full-fledged mania, bipolar 2, which is hypomania, and what bipolar disorder is in general, which is a fluctuation between depressive symptoms and mania. And then we have schizophrenia, which I think is definitely a psychiatric disease, but it's one of the psychiatric diseases that nobody seems to doubt is real. You know what I mean? Like when you have somebody, again, with an eating disorder, whether it be anorexia or whether it be binge eating disorder, or somebody who has a drug or a substance use disorder, I think that there is a common feeling that they should just control themselves. But people don't tend to say that about people with schizophrenia, even though schizophrenia is 100% diagnosed through behavioral symptoms, just like substance use disorder and eating disorders. So this is a psychiatric disease that's characterized by delusions, hallucinations, disorganized speech, grossly disorganized behavior, grossly not meaning like gross, but just meaning, big disorganized behavior, a large kind of disorganized behavior, weak emotional expression, speech, and specialization. there are two types of symptoms that are associated with schizophrenia that you'll need to know on the quiz and the exam, which is there are positive symptoms and there are negative symptoms. This does not mean good and bad. It just means, like with positive and negative reinforcement, either the additive or subtractive nature of what we're talking about. So the positive symptoms are delusions, hallucinations, disorganized speech, and disorganized behavior, and they're called positive because something is being added to the individual's experience that they can't explain, or is essentially, like with delusions, they believe that the government is out to get them. Or maybe if somebody with schizophrenia were watching this video, they would think that I'm talking specifically to them, right? Even though you all know that I'm talking to all of you. I'm looking at my iPhone and it's recording me. I'm not talking to anyone individually, but I'm talking to everyone, more or less. But people with delusions that are schizophrenic will think that I'm actually trying to send them secret messages. And this is, just to be clear, not a secret message to anyone. They will have hallucinations, and this is oftentimes, I think, kind of seen in like films like Donnie Darko, or I can't think of anything else. Donnie Darko just came up to the first one that came up to mind, but you'll be seeing somebody who's like looking at a visual hallucination. But from what I understand, the vast majority of the hallucinations that people with schizophrenia experience are auditory in nature. So they will hear things, and frequently it's very sad because they will hear things in the voice of people that they know and love, telling them kind of horrible things, like their brothers, their sisters, their dad or their mom telling them that they don't deserve to live and that they would be better off if they were dead, etc. Kind of really mean, nasty auditory hallucinations. So it can be horrible to deal with. Disorganized speech, like maybe some of you think that I have some disorganized speech. You never know where the end of the sentence is going. Sometimes they'll say things that don't really make any sense, as if it does. And then they have disorganized behavior that doesn't really make any sense, like kind of picking, like I knew a guy, I used to work at a Pizza Hut, and there was this homeless guy that kind of lived outside that I would talk to, and he would oftentimes be walking around and like picking, like it looked like he was like trying to pick someone up off the ground. So they have this disorganized behavior. They also have weak or negative symptoms, which are basically the removal of typical behaviors. So they'll have a weak emotional expression. So maybe you'll tell them something extremely distressing and they have no reaction to it. They'll have something called catatonia, which here I have not speaking or not moving for hours at a time. It is a really wild thing to witness, because you have people that will be on their knees in a praying position. Like we're talking about the kind of non-movement that we're talking about is like they'll sit in a position that looks extremely uncomfortable for hours. Okay, it's really unbelievable. Just go on YouTube and look at catatonia positions, and it's really wild that the human body is even capable of doing this. But catatonia is a symptom, a negative symptom, and then a lack of socialization. So variety, this is not all that surprising, but they don't have the best social skills. So you'll need to know examples of positive symptoms, examples of negative symptoms. And schizophrenia is one of those psychological dysfunctions that, although we don't know what's causing it, we can show that it does seem to have some kind of genetic predisposition. So the prevalence of schizophrenia in the general population is 1%, but it can go all the way up to 50% when you have monozygotic twins, which are identical twins, or children of two schizophrenic patients. So if you have two individuals, they both have schizophrenia, and though they have kids, the likelihood that their kids are going to have schizophrenia is almost 50%. And then you can see a variety of different things here. So children of schizophrenic mothers or adopted by non-schizophrenic mothers is 17%. Children in general is 13%, half siblings 6%. So there's a variety of different things here that have, or different populations rather, that have different prevalencies for developing schizophrenia. And this genetic predisposition for schizophrenia is also shown in adopted children. So if you have children that are adopted into a family, and the higher their genetic risk in conjunction with the higher of dysfunction of the adopting family results in higher outcomes of schizophrenia, right? So you do have some schizophrenia in severely dysfunctional families, even with a low genetic predisposition to schizophrenia, right? Like, as I said, all disease states, including psychological dysfunction, is an interplay between environmental stress and genetic predisposition. So even somebody with a very low genetic predisposition for schizophrenia, when paired in an environment with extremely high stress, can produce a negative outcome. So again, the point of this graph here is just to show that genetic risk clearly increases people with schizophrenic or the outcome of schizophrenia in a population. So environmental factors do seem to play a role, as we kind of already alluded to here. It's not zero. I mean, people with low genetic predisposition in a severely in a really bad environment can still develop schizophrenia. So poor prenatal nutrition is part of that, premature birth, low birth weight, complications during delivery, have a mild correlation with schizophrenia. Physical, emotional, or sexual abuse during childhood increases the risk and probability of developing schizophrenia. And traumatic experiences early in life impair the ability of the hypothalamic pituitary adrenal axis to produce its usual negative feedback relationship. And this results in an increased response to stressful stimuli. Or stressful situations. So again, this is another example of how something that you have no control over, which is whether or not your hypothalamic pituitary adrenal axis is over or underactive. And if you are somebody who has an overactive HPA axis and you find yourself in a super abusive childhood home, then your risk for developing this disorder is increasing exponentially, right? So again, just another example of this interplay between biology and environmental factors. And that's really important to think about, because this is not to degrade anyone's accomplishment. But if you have somebody who says, look at, I came from a bad neighborhood. I didn't join a gang. I came from an alcoholic home. I never picked up a drink. I came from this or that. I never reacted this way. I mean, partially that might be due to some biological protective factor that you have that maybe your sibling didn't have. Maybe your HPA axis is functioning properly. So although you did come from an abusive alcoholic home, you never picked up a drink because you were able to better regulate your feelings when that abuse occurred. Now, that doesn't mean to say that it's not abusive or that it doesn't have any effect. I'm just trying to point out again that it's not always so clear that just because you can point to certain environmental factors that what somebody else is experiencing. It's just, I'm just saying that empathy and trying to have a greater understanding of what may be causing somebody's specific circumstances in life can, in my opinion, help us, have a better society. But again, like all of these disorders we've talked about, there are some biological markers that are associated with schizophrenia, like enlarged ventricles. But we also saw this with like Huntington's disease, where there's also enlarged ventricles. So although there are oftentimes biological markers that are associated or correlated with these psychological or psychiatric dysfunctions, you can never diagnose somebody with schizophrenia because they have enlarged ventricles. You'll diagnose somebody with schizophrenia because they are convinced that the FBI has kidnapped their family and that they can hear their family talking to them through a radio or something. I'm just pointing that out. There are things that are correlated here, but that's not how these things are diagnosed. So the treatment of schizophrenia is through primarily dopaminergic activity. So this chart is just showing that the drugs over time have gotten better in their ability to control symptoms of schizophrenia. with a lower dose, but ultimately, schizophrenia and the treatment of schizophrenia is really rough because you can only really treat the positive symptoms of schizophrenia. So these drugs that are targeting dopamine receptors, they're really only going to help with the the hallucinations and stuff like that. There's still no treatment for the catatonia or the other negative symptoms that I have listed here: the lack of socialization, the weak emotional expression, the depression. You know what I mean? Like, these things are associated with schizophrenia, and they also have some severe side effects. Like, well, let's see. Do I need to go over the side effects? No. So some of the the dopaminergic antagonists, like they produce weight gain, they produce low sex drive, they produce potentially Parkinsonian effects at a high enough dose. So people with schizophrenia may get their schizophrenia under control, but then lack adherence to the treatment because the side effects of the drugs are too severe. They feel like they're zombies. They feel like they can't date. They feel a variety of things. So then they go off of the medication and then have a relapse with the with their schizophrenia symptoms. There's also a question about whether or not schizophrenia really is a disorder of dopamine. The most potent treatments that reduce the severity of the positive symptoms of schizophrenia are dopamine antagonists. Additionally, drugs that increase dopamine, like cocaine, meth, and amphetamine, can produce temporary psychosis at high doses. So when you do have somebody who's been on a meth binge for several days, they can resemble somebody with schizophrenia. And in fact, as far as I know, when you're diagnosing schizophrenia, one of the things that you need to make sure about your patient is that their symptoms aren't explained by drugs, right? So if you have somebody who's experiencing psychosis, you're not going to diagnose them with schizophrenia if they're like recently on a meth binge, right? So you have to first wait until they are detoxed from the drug to make sure that that psychosis is actually due to schizophrenia and not due to overuse of a psychostimulant. There is, though, evidence that has not been able to find higher concentrations of dopamine with those that have schizophrenia. And then, of course, there are also the negative symptoms that are associated with schizophrenia that are not explained by dopamine. So, I do go into it. So blocking dopamine does produce unwanted side effects. Antipsychotics produce their effects by blocking dopamine release in the mesolimbocortical pathway, which is, again, this VTA to the frontal lobe as well as to the nucleus accumbens, which can cause emotional side effects. But they also block dopamine in the mesostriatal pathway, which produces tardive dyskinesia. So the nigrostriatal pathway or the mesostriatal pathway, both of these pathways are important for movement, like I kind of already said. So you can develop tardive dyskinesia, which can be very distressing. It's kind of some people manifest it in a variety of different ways, but it is essentially a movement disorder that can cause involuntary movements, and once it starts, it can persist for a very long time until the person quits the drugs. And they can also become sensitized to it. So even though they quit, as soon as they start taking it again, the tardive dyskinesia starts up again very rapidly. So individuals may have like an issue where they constantly click their tongue in their mouth, which can be extremely painful over time. Tardive dyskinesia can be extremely, can be a very painful and unwanted side effect. There's other common side effects like a decreased sex drive, increased weight gain, and anhedonia, which again we talked about is a symptom of depression. And 1/3 of patients do not even respond to dopamine targeting drugs. So again, this is just to show that we have treatments for schizophrenia, but they're not perfect, and we don't really know what schizophrenia is on a biological level, unfortunately. So this is another thing where, it's just kind of pointing out that gray area that although people are really not going to doubt that schizophrenia is a disease, we really have no idea what it is on a biological level. We only can diagnose it behaviorally. So you don't need to know this whole chart here. I'm just showing that there is a glutamate hypothesis of schizophrenia, and drugs that manipulate the glutamate system produce both positive and negative symptoms of schizophrenia. So similarly to like dopamine, drugs like meth or cocaine can cause schizophrenic-like symptoms. So can glutamatergic acting drugs like PCP and ketamine, which are antagonists of NMDA receptors. And they can also induce relapse of symptoms for someone who has been asymptomatic with schizophrenia. So that's really scary. You can have somebody who's had years without any positive or negative symptoms of schizophrenia. They do PCP or ketamine, and then those schizophrenic symptoms come right back. So really horrifying. And the underlying hypothesis for the glutamate hypothesis is that there is a reduction in typical conditions, you have excitatory inputs to NMDA receptors in the hippocampus, and this causes excitatory transmission onto inhibitory neurons, which ultimately reduce the activity of glutamate neurons downstream. So we have an excitatory neuron, which is exciting an inhibitory neuron. If we excite an inhibitory neuron more, then that results in more inhibition. Okay, so this is one of those things in neuroscience that you kind of got to make sure you understand the logic chain, which I'll probably ask about this just because even if you don't really care about this in the context of schizophrenia, it's just a really foundational, important fact about how the brain works, is that you can have increased excitation, which ultimately results in increased inhibition. And that's because you have excitatory neurons synapsing onto inhibitory neurons, which ultimately increases inhibition. And here, the net result is a moderate release of glutamate in several areas. Now, in the schizophrenia brain, it could be the case that there's less NMDA receptors, which means less excitation onto inhibitory neurons, which results in greater glutamatergic release, causing immediate symptoms and later cell damage. So again, glutamate is the main excitatory neurotransmitter in the body. So if you have more glutamate, that means you're going to have more neuronal activity. And as we've already discussed many times throughout this class, more does not always mean better. More often means worse, and less means worse. You need to have a steady flow or moderate release, oftentimes, of all of these neurotransmitters. So some evidence that tendency towards schizophrenia starts with reduced NMDA activity. NMDA receptors stimulate neurons that inhibit downstream glutamate release. Reducing stimulation of inhibitory neurons results in greater downstream glutamate release. Increased glutamate release can result in too much glutamate and thus glutamatergic cytotoxicity. Okay, so this is essentially, you'll need to know the glutamate hypothesis of schizophrenia. I'll probably ask something about that because I like this kind of mechanism. So make sure that you know about that. This is our last bit of information here. So we are going strong. I know this is a bit of a longer lecture because of my incessant rambling and ranting, but we are almost done. So ADHD, attention deficit hyperactivity disorder, is a very controversial disorder, which is why I think I'm ending on it, because from both sides. I mean, people that are on TikTok and are learning about their ADHD, I would say is likely a problem. If the information that you've gotten about ADHD is coming from TikTok or Instagram, I don't think it's a good idea, because there's a lot of things that are said that are just not true. On those websites, it's and I mean on those apps and stuff, people just regurgitate the same thing over and over again, regardless of its validity. I'm not saying that everything you learn about ADHD on TikTok or Instagram is wrong. That's obviously not true. There are true things about ADHD said on these apps, but I just know that when I scroll through my feed, like, I just see things that are ridiculous. So on the other hand, though, you have people that are saying that ADHD is not real and that these people just need to control themselves. And again, as the kind of through line through this whole lecture has been, it may not really be realistic to just tell somebody with ADHD that they just need to settle down, right? So it's a behavioral syndrome characterized by a persistent presence of 6 or more symptoms involving inattention, impulsivity, or hyperactivity. It is characterized by extreme degrees of inattentiveness, impulsivity, hyperkinesis, and short attention span. And hyperkinesis just means moving around a lot. there are 3 subtypes. So this is why it used to be defined as ADD and ADHD, is because essentially now they've just kind of basically put that together into one syndrome. But nonetheless, they're still predominantly inattentive, which probably before would have been characterized as attention deficit disorder, predominantly hyperactive or impulsive, and then a combined phenotype with both inattentiveness and hyperactivity. This is typically seen in adolescents, but also has adult variations of distractibility, impulsivity, restlessness, hyper-emotionality, which is kind of a weird way just to say very emotional, problems at work and in interpersonal relationships, and a heightened risk for conduct disorder, antisocial personality disorder, and substance use disorder. So again, like all of these psychiatric illnesses, there is no diagnosis for ADHD outside of the behavioral characteristics. Now, you can go to a neuropsychologist and get a much more rigorous diagnosis than when you go to a 30-minute psychiatry appointment or a 30-minute general physician appointment. I'm not saying that those people are inaccurately diagnosing ADHD, but to give the devil his due, there is likely many more people diagnosed with ADHD than have genuine ADHD. And that is because of the resources that it takes to get properly diagnosed with ADHD. And when I say properly diagnosed, that doesn't mean being put in fMRI. It means going to a neuropsychologist and going through a battery of tests, which can often take, between 4 to 8 hours sometimes to properly diagnose. So now that doesn't mean that you can't be properly diagnosed by a psychiatrist. It's just that it's a lot harder to properly diagnose a disorder like this when you only have 30 minutes with a provider. Now, there are some hypotheses as to why ADHD exists or what is causing it, and one of those is hypofrontality, which is decreased blood flow or activity in the prefrontal cortex. The prefrontal cortex, as we went over in a variety of different ways throughout this course, is important for concentration and executive control over action. Therefore, decreased activity results in the symptoms seen in ADHD, and this helps explain the counterintuitive nature of using stimulants to treat ADHD. So, as I have here, basically the main treatment for ADHD are stimulants that increase either dopamine or norepinephrine or both. And that's because the idea is that while, yes, you're giving these individuals stimulants, which seems weird because they're already hyperactive, the reason why they're hyperactive is because their prefrontal cortex is not properly regulating their behavioral output, right? So normally your prefrontal cortex has or is giving you executive control over those intrusive thoughts that you might have, right? So you might think I don't want to give ideas of intrusive thoughts, but the point is that people with hypofrontality or people with ADHD, it might be the case that their prefrontal cortex is not operating properly, so it's not controlling those other impulses or racing thoughts or distracting things that are going on in your head. So if you give a drug that increases prefrontal cortex activity, then the idea is that will allow them to regulate their behavioral output. So I think that most people are familiar with Ritalin, which is a very common psychostimulant that's used in ADHD, especially in children. And this is a non-competitive reuptake inhibitor for dopamine and noradrenaline or norepinephrine. So it's a dopamine transporter inhibitor, you know what I mean? So it goes onto the dopamine transporter, it blocks reuptake, so there's more dopamine in the synaptic cleft, and this is, and also in norepinephrine. And here it says noradrenaline, but as we remember, norepinephrine and noradrenaline are the same, right? Ritalin binds to dopamine transporters and blocks the reuptake of dopamine and norepinephrine. This is actually how cocaine works also. I'm pretty sure I went over this in the psychostimulant lecture, or in the psychopharmacology lecture, and I'll go over it again in the next lecture, so for sure I'll be asking how cocaine works. But Ritalin and cocaine work very similarly. And this is why I had a whole rant about how drugs aren't necessarily bad in the psychopharmacology lecture. But yeah, it blocks reuptake of dopamine, which increases prefrontal cortex activity. And then we also have Adderall, which blocks and reverses dopamine and norepinephrine transporters. So here we have transporters that are vacuuming up dopamine and norepinephrine over here on the left side of this little graph that I made. And then you add Adderall, which then blocks and actually, so one mechanism is that it's blocking the transporters, so the dopamine and norepinephrine can't be sucked back up, but it also is just straight up reversing the transporter, just like methamphetamine, or ecstasy, or a variety of drugs. So again, now there are different pharmacokinetic and pharmacodynamic properties of these drugs, which is why they're not just the same. It's not like people are getting prescribed meth or ecstasy to treat their ADHD, right? It's not completely the same, but I'm just pointing out that they have a similar mechanism of action, although their pharmacokinetic properties are very different. But yeah, you'll need to know the mechanism of action, which again is the blocking and the reversal of dopamine and norepinephrine transporters. And ultimately, the idea here is that when you have too little norepinephrine or dopamine, you are fatigued, unable to control behavioral output, etc. As the activity of your prefrontal cortex increases with optimal norepinephrine activity, this is an alpha-2A receptor, which is a norepinephrine receptor, and D1 activity, which is obviously a dopamine receptor, then we get the proper activity in the prefrontal cortex, which allows for individuals to pay attention, not overreact or be hyper stimulated or hyper moving around and stuff like that. And then once you get excessive norepinephrine and dopamine, then you get stressed and you get all of the negative side effects of too much dopamine. So again, this is just kind of a graphic to try to show that when individuals are suffering with ADHD, it's because they have too little or too much of this activity here, and that the optimal activity of norepinephrine and dopamine will allow them to reduce their ADHD symptoms. So overall, for ADHD, you'll need to know how Ritalin and Adderall works. You'll need to know about the 3 subtypes of ADHD, about the glutamate hypothesis, the dopamine hypothesis, because a lot of these things are kind of have similar. They have similarities across different disease states. So hypofrontality and excessive glutamate are characteristic of many psychiatric diseases. So I hope that this was informative. I hope that it's clear, what it is that I'm going to ask about and stuff like that on the exam. I will try to get a study guide out very soon. And this means that although this was a very long lecture, you only got one left to go, which is substance use disorder. Again, my PhD was basically in learning, memory, and preclinical models of substance use disorder. So that's why I'm going to put a whole lecture on it to talk about the neuroscience of drug addiction. So I will see you in the next video, and good luck on the Module 3 exam, which you guys, this will not help you now, but it will be due tonight at 11:59, and it's Friday. So I will see you guys in the next video.